The patient is a 64-year-old man diagnosed with a pheochromocytoma of the right adrenal gland. The tumor locally invaded the right kidney, the retrohepatic vena cava, and the caudate lobe of the liver. The IVC at the level of the renal veins is free from tumor. The root of the right hepatic vein is free from tumor, as is the root of the middle left hepatic veins. The tumor thrombus is present in the suprahepatic IVC. The surgical plan calls for a right adrenalectomy and nephrectomy, resection of the caudate lobe of the liver, and resection of the IVC, superior to the renal veins and inferior to the hepatic veins. After bilateral mobilization of the liver, the tumor and vena cava are dissected. The right renal arteries are divided, and the right renal vein is stapled. At the porta, a retrograde cholecystectomy is performed, followed by cannulation of the main portal vein in anticipation of the in situ cold perfusion of the liver. A Rommel tourniquet is put in place downstream of the cannulation site. Umbilical tape is placed under the roots of the 3 hepatic veins. The right arm is positioned under the right hepatic vein and traverses between the right lobe liver and the tumor. The umbilical tape delineates the lateral border of the caudate lobe, where it meets the tumor. The left arm is positioned to trace the caudate groove. Which delineates the medial border of the caudate lobe. This liver sling creates a virtual plane which isolates the caudate lobe, leaving the hepatic veins intact with the remnant liver. With hydrojet dissection, the caudate lobe is detached, to be removed en bloc with the retrohepatic vena cava along with the specimen. Before dividing the cava, the veno-veno bypass is set up. A tubular channel, created using bovine pericardium, is connected to a site on the infrarenal vena cava. A similar channel is connected to the SMV. The channels are connected to Mackay arterial catheters that are joined together at a Y junction. The Y junction directs flow to an ECMO machine, and the outflow is recirculated back into the patient through the right internal jugular vein. Once the bypass is established, the portal inflow is occluded. The cava is clamped just above the renal veins, as well as above the hepatic veins, with cold preservation fluid flowing through the portal vein to the liver. The vena cava is divided. The specimen is removed and the cava is reconstructed with a PTFE graft. The cold perfusion setup is removed, followed by the caval clamps. The veno-veno bypass setup is stopped. The Mackay catheters are removed from the tubular channels, and the channels are stapled closed. The use of tubular bovine pericardium channels throughout the bypass phase helps preserve the integrity of the veins as well as improve the efficiency of the procedure.